Get you.
Just
Okay, great. Go.
That's the expensive one.
go ahead and sign everything.
You know what? I'm not in there. Yeah, exactly. There's no realistic reason that I'm going to use it later.
You've been sitting, right?
Oh, we've been sitting.
If you want to sit,
Is this sorry?
Dito kaya.
so I sent you online different parts of the body where you can measure pulse. All right, so please go through them. You have different types of pulse because at times, for one reason or the other, you're unable to get pulse in one part of the body, especially when patients get sick. The pulse may get so weak that you're unable to feel the wave on some certain of the arteries. So get familiar with all of them. And when you're assessing pulse, usually you'll be looking at a pulse, you should describe the quality of a pulse in terms of is it strong, is it weak, is it regular, is it irregular. You can go to other descriptors in terms of the quality, in terms of it's bouncing, threading, it's pounding, different descriptors of how strong it is or how weak it is. But at least global level, you should know whether a pulse is strong enough or is weak. And the rate of repetition is irregular or irregular. When the rate is regular, you can use like 15 seconds to estimate the heart rate because each time the heart beats during systole, the waves of the explosion of the enlargement of the aorta, that wave is travels along all the arteries, and that's what we are calculating for. So you can use the pulse to calculate the heart rate, how many times the heart beats per minute. If it's regular, if you describe it as regular, you can measure for 15 seconds and times by 4. If you describe it as irregular, you have to measure for 1 minute because for obvious reason. So that is pulse. Then we also measure the blood pressure, all right? So blood pressure, we use a stethoscope and a sphygmomanometer. The standard position for our blood pressure measurement is the patient is sitting, all right? But we can also measure the patient in standing with the patient in lying. Two key things you need to note when you change positions. Number one, you don't want active contraction of the muscle, the hand, or the limb where you're measuring that. I want to use limb. We usually measure in the arm regular, but when patients have some contraindications where we can measure in both arms, we can use the leg, we can use the other parts of the limb to measure the blood pressure. So you want to make sure that the limb, you are supporting it. So if the patient is standing, I'm carrying the patient's arm. I'm not telling the patient to hold up the arm. All right. So if you're measuring blood pressure, you notice the patient is holding his arm. No, you have to tell the patient to relax and you support. That's what you pass it because the contraction of the muscle will add some pressure, which will get minus from the pressure within your cuff. The next thing you will need to know is if you're using anything other than the standard position, is that the cuff on the patient's arm should be at the same level with the heart. So if I'm lying down, my heart is slightly anterior here, my hand is here, then I will need a pillow to bring it up so that the cuff is at the same pressure with my heart. If a cuff is lower than my heart, my blood pressure increases. Above my heart, my blood pressure decreases. All right? And then if you measure it in any position other than the standard sitting position, you note the position. So that if somebody measures it again, the person will be able to correlate the values to know this was a lying down position, this is a sitting position. So when the patient comes in for your blood pressure measurement, and you see the way she's relaxed, that's where we relax. In the exams, in the clinic, you see most of your patients who are sitting relaxed this way. You don't measure blood pressure this way. So I bet you, even without telling your SPs anything, if you meet them in sitting position, 60% of them are going to be sitting this way. And that is going to change the blood pressure values. So you want to make sure the 2 feet are flat on the floor. All right? The patient should be seated for about 5 minutes before you measure blood pressure. That's why at times they call you in and you're seated before they come to bring the blood pressure kit. The patient shouldn't have taken anything like caffeine in the last 30 minutes. Those can affect the blood pressure. If they do, and you need to measure it in a clinical session, you need to note it. I mean, patient took caffeine in the last 30 minutes. But you have to measure, but you need to take that into consideration in interpreting the values that you're having, knowing that that could have altered the values you have. You're going to be moving from one patient to the other, so you always have the wipes, and you need to clean the blood pressure, the bell. So we always assess with the bell. Sorry, the diaphragm of the stethoscope, never the bell, the diaphragm. So make sure you clean it and you warm up your stethoscope so that the patient don't feel cold from the steth in our environment. So, and then you're going to have so in the sphygmanometer, we have the cuff, which will wrap on the patient's hands. Inside this cuff, we'll have a bladder. So this bladder, it's where the air that I'm pumping from here goes into. All right? So it is the pressure in this bladder that my sphygmanometer is measuring. All right? So what is happening in the blood is, so you see my bladder here. So ideally, I failed, Dr. Spahia reminded me and I forgot. I'm supposed to have brought some spigs from the school because the spigs we have in the school have different sizes for different arm circumference, because the length of this bladder should cover at least 80% of the circumference of the arm for me to get my something that is closer to the blood, so the pressure within this cup will be very close. I'll be able to estimate the pressure on the artery that I'm using to assess. So you need to make sure if your clinic has different sizes, that you have the appropriate one. Always deflate the cup before you start. All right. So you deflate the cup completely. This knob is for opening the air to come out from here or keeping it closed so the air doesn't leak. So anti-clockwise is open, clockwise is closed. Normally, clinically, we'll hold it this way. I know when students start learning, they hold it this way. But normally, this is the way, because at times you need your other hand. Okay. So, if I want to measure her blood pressure, I'm going to have her, she has been sitting for about 5 minutes, remove her clothes. So the cup will always make direct contact with the skin. The more layers I put, the more I'm putting a difference between the pressure in the artery and my blood vessel. So in the material I sent you, which you did, you're not going to see anybody doing it in clinic. They find a midpoint of the arm. They measure from the acromion to the condyle, and then they get a midpoint so that they can play the cup appropriately. Most importantly, what I want you to do is make sure that the cup is positioned at least 1 to 2 centimeters above the cubital fossa. So that should be around 2 finger breadths, all right? And then you see this cup, this is my bladder. You see in the middle of my bladder, I have this called arterial index, arterial marker. So this is supposed to point to the artery. But now my reference here is the artery in the arm. All right? So where is the brachial artery in my arm?
Under the bicep?
Okay, good. So by the side. So my brachial artery is usually by the side. So I want to keep this as much as possible. That keeps it like in the middle of the artery. All right? Because that's my brachial artery there. In the cubital fossa, my brachial artery is here. But in the arm, my brachial artery is a little bit by the side. So it is just so that the pressure point in the bladder, it's just centered on the artery. So now, as I have the cup, I have about 1-2 inches above. I make it snuggy enough, but I should be able to fit 2 fingers in between. All right. So I'm ready to measure. The first measurement I'm going to take is what we'll call the pre-obliteration. I will change that up. So what we'll call the estimating the pre-obliteration pressure, all right? Because I'm seeing her for the first time, I don't know what her blood pressure is, so I don't have an idea of how much I should pump my speak to, all right? Because what is happening in blood pressure measurement is that I increase the pressure in this bladder until the pressure in the bladder gets above the systolic and diastolic pressure. At such a point, there is no blood flow into the arm, right? Then I start releasing it. When I get to the systolic blood pressure, during systole, blood will flow in. During diastole, there will be no blood. So with each systolic beat, I'll get boom on my stethoscope, I'll hear it, all right? And I will keep decreasing the pressure in this manometer until I get below the diastole. And when I get below the diastole, then blood is flowing both during systole and diastole. The blood is flowing. At such a time, those sounds I'm hearing will stop. And what we call normal laminar flow is restored back in the arm. Normal laminar flow, the stethoscope can't pick the sound. So the stethoscope can only pick the sound when the blood is pushing through an occlusion. So that is when I hear the sound. So the first one I hear is my systole, the last one I hear is my diastole. The only instance is where you can't hear with the stethoscope some sounds when there is no occlusion is when patients have something like atherosclerosis. So you have the intima of the blood vessel is not smooth, so disruption of that flow can create sounds. That sounds like blood pressure. But ordinarily it's laminar flow, you don't hear anything. So for me to estimate how much I should pump this, I do what I call pre-obliteration. So what I'm going to do in this, I'm not using my stethoscope, I'll just find her radial artery or her brachial artery, anyone, all right? And I'm feeling the pulse. And then I begin to pump this. I'm going to pump it at a rate of about 10 millimeters of mercury per second as I'm going up, all right? Just to go quickly. Each time I'm measuring blood pressure, I don't want occlusion for a very long time, because if I'm occluded for a very long time, I create ischemia. If I create local ischemia, I'm going to have local increase in blood pressure just on this arm, and it's going to give me falsified values. So for that reason, you don't keep this occluded for a very long time. If you make a mistake along the line, you deflate and allow reperfusion so that ischemia, it's gone. You don't have that local increase in blood pressure, because that can falsify your values, all right? So my first pre-obliteration, I pump up at about 10 to 20 millimeters of mercury per second, and I'm feeling my pulse. Once I get above her systolic blood pressure, I'm not going to feel her pulse again, like I don't feel it right now. I go about 30 millimeters of mercury above it, and then I gradually decrease at a rate. You can come and see the way I'm lowering this at a rate of about 2 millimeters of mercury per second. Not too fast, not too slow. And I feel when did I feel her pulse come back. Remember when I was going up, I was doing about 10 to 20 millimeters of mercury per second. So I just have a range, I don't have a value. All right. So as I'm coming down, I'm able to confirm a value like, oh, it came back around 110, it came back around 120. So I say, okay, her systolic blood pressure is around 120, it's around 110, it's around 90. So I pause, and I'm going to give her 2 minutes to rest so that I have good reperfusion. I don't have an increase in blood pressure. Otherwise, if I want to measure immediately, I'm going to switch arms. All right. Usually not the ideal thing, so you just wait for 2 minutes and then you remeasure. So if you make a mistake, you wait for 2 minutes. In an exam situation, you may not have that 2 minutes to wait. So when you say that, ideally I'm going to wait for 2 minutes, then I'm going to repeat these values. Because at times you're working with these students, you tighten this too tight, and then you want to lose it, it goes down and everything goes down. You just made a mistake. So you should wait for 2 minutes. When the exam situation, you say, I'm going to wait for 2 minutes, and you have to work because you have a time frame. So after 2 minutes, then I'm going to use my stethoscope. And I place my stethoscope on the brachial artery. And when I place my stethoscope on the brachial artery, do you expect that I'm going to get anything? No, because that is laminar flow. All right? So I'm not going to hear anything until I have an occlusion and the blood and the heart is pushing through the occlusion. So as I place this, I'm not hearing anything, right? So now I'm going to pump. And I pump quickly to around 120 for her, and then I allow this to come down gently. So I see come back at around 88, and I heard the last sound around 64. So that becomes my systolic and my diastolic for her.
Seems
All right.
very low, no? Like, is that, like, shouldn't it be around 120 over 80?
So 100, 100 to 120 for systolic and 60 to 80 for diastolic. So her diastolic is fine. Her
Oh,
systolic
okay,
depends
okay.
on athletes and people who run at times can have like slightly lower blood pressure.
But when you measured the pulse with radial artery, you
Felt it come back around 90.
90?
Yeah, so I pumped up to 120. So my second time, I just pumped quickly to 120 because I had that estimation when I was measuring her pulse
So
coming
you're
up.
going 30 millimeters of mercury
Above.
above where
Yeah.
you think her systolic
Yes.
is, or diastolic.
Her systolic. Yes. So 20, 30 is fine, 20 to 30, but ideally 30. So you come down gradually and you remeasure. So that is my systolic, that's my diastolic. If I'm seeing the patient for the first time, ideally I should take the measurement 2 times, and I should take it on the left. I should measure the left and right hand, know the one that is higher, and repeat that twice. And then subsequently, each time I see the patient, I use the same arm. All right.
So the one that's higher, you do twice?
Yes. So in the hospital situation, you're going to say, I'm going to measure it twice. I take left or right, and I see the higher value, and I repeat it the second time on the arm with a higher value. So that is this blood pressure measurement. Now, another outcome measure we're going to do is the ankle brachial index. All right. So the ankle brachial index, I'm sure you should have done a little bit of this in ortho. All right. So just here we're doing the practical aspect of it. So can anybody remind me what the ankle brachial index is? So ankle brachial index of the right lower limb is what? Right leg.
Is it in relation to the highest pressure of the lower extremity over the highest pressure between the right or the left arm?
Okay. Similar. Highest pressure of the lower extremity. What do you mean by
Because
that?
you can
The
take it from
ankle,
the
the right
dorsalis
ankle.
pedis
Okay,
or
okay. Of the right. Okay,
Yeah.
good. So
You take it from both.
You
yeah,
take from both and then you
Yeah.
calculate it by picking which one is
it's
higher.
highest. Yes. So that's what we're gonna do. We have Dr. Pahia.
And just, in the notes that you have, sorry, here. This is uploaded.
Yes.
So, just to clarify, we're gonna be talking more about this when I'm gonna be talking about peripheral artery disease, but it's a measure looking at the circulation, right, happening in the lower extremities. So you are calculating one for the right and one for the left, right? But then overall, you pick, because it's a ratio, right? So the smaller the number, the more severe the obstruction is in the lower extremity, the worse the peripheral artery disease, okay? So whichever from the right or the left is the smaller ratio, that's the one that you use to consider what is the overall kind of relative disease level that the patient has. And you have here the different levels, okay, in terms of the ratio, 0 to 0.4, 0.4 to 0.7, and so forth, in terms of severe, moderate, mild, and disease.
Okay, so 2 key important things for me to mention on the ankle brachial index. So we are comparing pressure on the arms to pressure on the legs, right? Because it's the same circulatory system, the same heart, but we're checking for the integrity of the blood vessels. For you to do that calculation, the heart and the legs have to be at the same level. In other words, if I measured her blood pressure in lying position. I can't use the blood pressure I use in lying position when I get on bed to measure the leg. So do my estimate. I have to get her supine lying blood pressure. That is the value I'm going to use.
So for both the arms and the legs?
Yeah, I have to put her in supine. And I can't measure her legs this way in sitting position because her legs are lower than the level of her heart. One more thing I think I also want to mention on this is we are using only the systolics. All right, so if I'm doing only the ankle brachial index, I'm only interested in the systolic. On the lower limbs, for the dorsal pedalis, it's possible at times to get low blood pressure with the stethoscope. But for tibialis posterior, it depends on the groove of the patient, how deep the artery is. At times, you can't place a stethoscope there. So it is easier for you to just use your finger the same way I did the obliteration for the hands. Since you need only the systolic and get the systolic for the lower limb. So it's easier than using a stethoscope, except if you actually need blood pressure on the legs. So you can use your hand, use your obliteration pressure, just get your systolic and do your calculation. In the hospital these days, thanks to technology, we'll have the Doppler ultrasound, which Dr. Swahili has gotten one for the lab. We're lucky, so she will go around and try it on different individuals. You see how it magnifies the sound. And unlike the stethoscope, the Doppler can pick sound from laminar flow. Remember I told you laminar flow the stethoscope can pick. So if I put these on a blood vessel just flowing, you hear the flow, all right? So with each beat of a heart. So we use that. In the hospital, that's what they use. So they use it to get the systolic. Find the point of occlusion. When there's no sound and when the sound comes back, they pick that value. Then get for the arms and they do their calculation. So we'll be doing that for the lower limb for our ankle brachial index.
For the ankle brachial index, actually the Doppler is the gold standard, okay? In terms of accuracy, this is what you should be using. Poor man's method is the pulse.
Because that can get into this groove here easily and can pick sounds from that. So finally, we'll have the pulse oximeter. Some of you have seen that in our lab on Wednesday, so we'll get to try it out in terms of placing it on the patient. Remember what to tell the other group: nail beds, nail polishing, paint, all those will affect your value. So you want to make sure that the patient's nails are clear, the hand is not moving. There are some artifacts when you move, you see the value change. It's stable, so you use it to get both the heart rate and oxygen saturation, hemoglobin saturation.
You have a page also in terms of blood pressure measurement, lying down, sitting, standing, doing jumping jacks, just so that you can see how it potentially changes or not. Okay? So it's something that you should try to understand also.
So we'll have 5 beds. We're going to pair up. Those are people that want to start with the ankle brachial index, start with the beds. People that want to start with the blood pressure, use the tables, and then we'll switch over. All right. And practice the pulse oximeter. You can compare the heart rate you measure manually with the heart rate from the pulse oximeter. All right.
Can't get up.
Hello, Megan. How are you? Your partner? You have a partner to work with? And you work together?
Oh, and you can talk to me.
Yeah, she's there.
Okay.
She saw you in the front.